sir. My name is Sudeep, and I'll be presenting a case of a 71-year-old man whose chief complaints were fever of 3 days duration, vomiting of 3 days duration, and altered mental status for 2 days duration. So this man was apparently asymptomatic until 3 days ago when he developed fever, which was acute in onset. It was high grade in nature and it was associated with chills and rigors. There is no history of dysuria or burning micturition. There is no history of food consumption from outside or any raw milk or unpasteurized milk. No history of any cough. No history of headache or seizures. No history of loose stools, blood in stools. No history of any myalgias or arthralgia. No history of yellowish discoloration of the skin. No history of any rash. No history of loss of appetite or weight loss. It does not give any history of any nasal discharge, throat pain, dysphagia or facial pain, and there is no history of contact with COVID-19 or TB patients. This fever was associated with vomiting, which was acute in onset. There were 2 episodes of vomiting. The vomiting was non-projectile, non-progressive and non-bilious. It was not associated with any blood in the vomitus, but it was associated with nausea and constipation for 2 days duration. There is no history of any abdominal pain or photophobia. There is no history of relationship with timing of food intake. There is no history of any head trauma. There is no history of dizziness or tinnitus. The patient was fine for 1 day, after which he developed altered mental status, which lasted 2 days. It was insidious in onset and it progressively worsened over the past 2 days. So after this, the patient was taken to a local hospital and was referred to our institute for further management. The patient also gave a history of progressively enlarging lower limb swelling. The patient is a known diabetic over the past 10 years. He was prescribed insulin but is non-adherent to his medication. The patient gives a history
if possible, when you are taking diabetes history, you should ask what is the last HbA1c.
Yes, sir.
Because we should get some patients will tell my sugar is normal. Today my sugar is 88. That doesn't mean that he is under control. So HbA1c will give the last 3 months sugar average value. So we should always try to ask whether they have done it or not. If it is done, you can tell now itself. Because if the HbA1c is 8 or 9, we can know that this patient is not having any control.
Yes, sir. The patient is a known hypertensive for the past 12 years and is a known history of coronary artery disease and status post coronary artery bypass graft in 2016. And the patient also had an old CVA in 2018. So presently his drugs are Ecosprin 75 mg, clopidogrel 75 mg once daily, rosuvastatin 20 mg once daily, carvedilol 12.5 mg twice daily, and insulin, which he is not adherent to. Moving on to the personal history.
What are the compelling indications for insulin? So in a diabetic patient, which all patient must take insulin?
So patients who had been on OHAs previously, initially on one and then later requiring more than one OHAs, but still not able to have glycemic control.
That means secondary OHA failure. Patient was on OHA, now OHA is failed, you have to put him on insulin. That is secondary OHA failure.
Yes, sir. Or primary.
Primary OHA failure is mainly seen in young individuals like type 1 diabetes or MODY and all.
Yes.
Then other conditions. Patient who are pregnant ladies, we don't prefer to give other drugs. Some like metformin and all, now it is recommended, but most of the doctors still prefer insulin only because we get better control in pregnancy. So pregnancy is one indication. Then emergencies like diabetic ketoacidosis, hyperosmolar coma, and other emergencies like trauma, surgeries, myocardial infarction, stroke, all these emergency condition, we have to put the patient on insulin. And patient who develops secondary problems like diabetic neuropathy, diabetic nephropathy, diabetic retinopathy, all these patients, insulin improves the clinical picture. So in that diabetic, suppose somebody is having diabetic nephropathy, when we give tablet, sugars will be controlled, but it will not improve the kidney status. So once the patient develops end organ damage, insulin is the only drug which can reverse it or arrest it. So whenever patient is having end organ damage, better we should put the patient on insulin. Okay, but that is not a compelling indication. If we start, patient will get benefited. Other things are compelling indication.
Yes, sir. Patient is not known drug allergies, and there is no history of any intake of drugs which are known to cause fever. Moving on to the general examination, the patient is well built and nourished. He is drowsy but arousable. There is no pallor, icterus, clubbing, cyanosis or lymphadenopathy. There is edema present over the left lower limb, which is pitting in nature.
Okay. So when we have a patient who is having edema, we should know what are the reasons for edema. What are the causes for edema?
Sir, first we will categorize the causes based on whether it is a unilateral
or bilateral. Unilateral edema causes?
More local causes, infections, inflammation.
Like cellulitis. Okay, cellulitis or
necrotizing fasciitis.
Okay, then?
Or DVT.
Then?
Filariasis.
Filariasis is a non-pitting type of edema.
Yes.
Okay.
And if it is bilateral, it points more towards systemic causes like cardiac failure.
Okay. Again, you start from one area. So top from you start, you can see the eyes, anemia. Then thyroid gland, hypothyroidism. Then heart, right heart failure. Then lungs, COPD with again right heart failure. That is called as corporal malaria. Then abdomen, liver, chronic liver disease produces hypoalbuminemia. Then other condition, kidney, nephrotic syndrome or protein losing nephropathies. Then intestine. What are the causes in intestine? Protein losing enteropathies or malabsorption syndrome. Both can produce edema. Main cause of edema is hypoalbuminemia. But here your patient has got unilateral edema and is diabetic. So we should think about
infectious etiology.
Cellulitis, infectious etiology. Okay.
The patient's pulse was 93, regular rhythm, normal volume and character.
Okay.
No radial or radiofemoral delay.
Okay.
All
in this type of patients, you can use handheld Dopplers, which is available in emergency room, so that you can get sometimes you don't feel the pulse. If you are not getting the pulse, it's an emergency. But if you are getting pulse with your handheld Doppler, in this type of patients, the patient is on the safer side. Yes. So always try to use that handheld Doppler, which is freely available, that you can use to count the pulse. Okay.
The patient had a blood pressure of 130/70 with a mean arterial pressure of 90 millimeters of mercury. Respiratory rate was 20 per minute, regular pattern, abdominothoracic type, and the patient was febrile with a temperature recorded as 102.8 degree Fahrenheit. So first, considering his extensive lower limb edema, I would like to proceed with the local examination. So on inspection, there is an extensive edematous area on the left lower limb measuring roughly 20 into 7 centimeter, extending from 2 inches below the knee to 1 inch above knee joint to 1 inch above the ankle joint. It is associated with erythema, and there is presence of multiple petechiae. The surrounding skin is hyperpigmented. There is no discharge or ulcer seen in the area, and there is no. It does not appear to be pulsatile. On palpation, there was a local rise of temperature. The swelling was tender. The size was confirmed to be 20 into 7 centimeter. It had a smooth surface and did not extend into the subcutaneous tissue. The margins were ill-defined, and there is a certain degree of pitting on pressure. It is not fluctuant or translucent. There is no crepitus. So the regional lymph nodes were palpated, and there was no regional lymphadenopathy that was palpable. So moving on to the other systems, on examination of the CNS, the patient was not oriented to place, time or person. There were no cranial nerve abnormalities. Motor and sensory system were within normal limits. There were no signs of meningeal irritation.
Diabetic patient, what sensation you want to check? Most important sensation loss is what? So vibration sense. Okay, if you are examining in detail, you will examine everything. But in a quick examination, you have to always check for the vibration sense in diabetic patients, because that is one of the earliest sign of diabetic peripheral neuropathy, loss of vibration sensation. Okay.
Yes. Respiratory system examination, there was bilateral air entry present, but crepitations were heard bilaterally in the infraaxillary, interscapular and infrascapular areas.
What is the age of the patient?
71, sir.
71 years, crepitations in lungs are normal.
Old patient.
Old patient, you can get crepitation. If there is a clinical correlation, it may have some value. Otherwise, it does not have any value.
All other systems were within normal limits, sir.
So, what is your diagnosis?
So, I would diagnose it as a case of cellulitis.
So, in emergency room, you will diagnose it as cellulitis. How do you confirm, or what else you rule out before proceeding?
So, I would like to do ultrasound Doppler to rule out DVT.
Okay, DVT should be ruled out immediately, because if whatever examination you want to do, DVT should be ruled out. Okay, in this type of cases. So, better to do a Doppler and rule out deep vein thrombosis.
Yes, sir. I would also like to get other investigations.
Okay.
CBC, CRP, and prior to treating the infection, always 2 sets of blood cultures I would like to send, sir.
Okay.
Then urea, creatinine, because the patient is encephalopathic, we should find out the
urea and creatinine. Urea will be elevated, and if there is renal failure, creatinine also will be elevated. That itself can produce altered behavior. But here the altered behavior is mostly due to
infection.
Toxic encephalopathy, due to infection. Okay.
Then other routine investigations like chest X-ray, sodium potassium levels, LFTs.
Okay.
And procalcitonin can also be checked.
Okay.
So those are the.
So what anything you got in investigations?
So CRP and CBC levels are elevated.
Okay. So counts are elevated, CRP is elevated. That shows some sort of infection.
Yes, sir. And urea and creatinine were also elevated.
Diabetic nephropathy with aggravated due to the infection.
Yes, sir. The sodium was also deranged, sir.
Sodium is low or high?
Low, sir.
So hyponatremia is there. How do you treat this patient?
Sir, two things we must treat, sir. First, we must treat the underlying cause, and we must also.
So diabetes is there, that should be controlled. What is the sugar level? Sugar level, if it is high, we have to treat it. Then infection we have to treat. Hyponatremia we have to treat. So diabetic part should be treated with insulin. Better to start insulin infusion. Okay. So that you get a tight control. If you give subcutaneous, what will happen in this type of patients?
Sir, won't be enough.
It will not be getting into the circulation, because patient is having like severe infection, dehydration can occur. Whatever you are injecting subcutaneous, it takes longer time to get into the systemic circulation. So in a sick patient, you can give infusion. One advantage of infusion is whenever patient go to hypoglycemia, you can stop it. Immediately it stops there. But if it is given subcutaneous, it may act for longer time. So when you are admitting in ICU, better go for infusion if possible. If not possible, subcutaneous is also okay. So insulin should be started. Then infection, how do you treat?
Sir, we would like to empirically treat it with antibiotics while we are awaiting the.
So what antibiogram you are suspecting, or what is the organism you are suspecting?
So we are since it is a skin, it's a cutaneous lesion, we will be suspecting gram-positive infections.
Gram-positive cocci.
Mostly streptococci and staphylococci.
Okay. Both most common infection is streptococcus and staphylococcus. Both can possible. And if the patient is already admitted in a hospital, different hospital, you have to suspect MRSA, methicillin-resistant staphylococci. Okay. And
since the patient is diabetic, I would also suspect Pseudomonas.
Pseudomonas also. So chronic infection can produce gram-negative supra-adult infection. Pseudomonas should be suspected.
Yes.
So how do you treat this patient? If it is you are suspecting a fresh case, you are thinking about gram-positive cocci like staphylococcus or streptococcus. What is the ideal antibiotic?
Ideal antibiotic would be penicillin-based.
What penicillin?
Regimen, sir. Either penicillin-based regimen with the beta-lactamase activity like amoxicillin clavulanic acid.
If you are thinking about streptococcus, amoxicillin clavulanic acid is the best drug. If you are thinking about staphylococcus,
if it is methicillin sensitive, we will go for flucloxacillin.
Flucloxacillin is the ideal drug. If it is resistant,
vancomycin.
Vancomycin should be started, or linezolid, whatever, depending on your clinical scenario, you can start. But the problem is this patient is having as infection with early shock or sepsis. What other drugs reduces the toxicity of the infection?
So we can hit hard by going for higher level.
No, higher level we should not go. We should go from this base level itself. We have to add another drug, that is clindamycin. Why clindamycin is added?
Gram-negative coverage.
Clindamycin is added to prevent the production of toxic materials. Okay, when you are giving a drug like flucloxacillin or augment, clindamycin can be added to the drug to reduce the toxicity. So otherwise this patient may go to toxic shock syndrome. Okay. So you can give flucloxacin with clindamycin. Okay.
And if it is a pseudomonas,
no, then you have to go for gram-negative coverage. What you had?
Third generation cephalosporin sensitive to pseudomonas like
Pseudomonas will not be covered by normally by third generation cephalosporin. You have to go for a higher antibiotic like piperacillin tazobactam, meropenem or piperacillin tazobactam. So you have to give a combination of, when you are treating empirically, you have to give a combination of flucloxacin, clindamycin with piperacillin tazobactam. That covers everything. If you know what is the organism, then you can go specifically. Once you start empirical treatment, that may contain these 3 drugs. And once you get the culture, you have to de-escalate. De-escalation means you remove unwanted antibiotic, give specific antibiotic. How long you treat this patient?
Sir, 10 to 14 days.
You may require minimum 2 weeks. Then?
And that is IV, and then we will change over to oral antibiotics
then
once the patient is
after
stable.
that? This patient may require prolonged antibiotic prophylaxis. You can give Pendits. Pendits is a oral penicillin, or any penicillin will be okay, but this is a safe penicillin. Many patients get benefit from that. Pendits is oral penicillin we use for rheumatic heart disease prophylaxis. Same drug can be tried here, or if the infection is more, you can go for higher drugs, but that may require longer time, 3 months and 3 to 6 months we have to give. Otherwise, again, this patient will come back with infection. What other strategies are very important?
Sir, limb elevation.
Limb elevation is very important.
And since he might have diabetic
peripheral neuropathy,
proper limb care and regular inspection to see if there is.
You have to see the skin. Most of the time, skin will be very smooth. Loss of hair follicle will be there. There will not be any sweating. Dryness will be there. It's all part of diabetic neuropathy. Skin will be dry and smooth. So in that case, you have to like give massaging. All those things you have to give.
Moisture.
Okay. Can you think about any other joint disease here in this type of patients?
Osteomyelitis.
Charcot joints. Charcot joints are very common in diabetic patients. So you have to examine in detail. You may have to take an X-ray. All these things. You have to examine for foot problems, callus, all these things. Foot care should be given for all diabetic patients. There will be fungal infection. There will be nail infection. So all should be treated. Proper footwear should be advised. Okay. What are pressure points in leg? Any pressure points will be there. So pressure point improvement can be taken from diabetology department. So you get a pressure point imprints, and you have to avoid pressure on that area. Otherwise, they develop pressure sores there. Okay. So that all things should be avoided. Okay. So you have to give proper foot care for this patient. Otherwise, again, this patient will come back. Antibiotic prophylaxis can be given. Sugar should be tightly controlled. How do you know that sugars are controlled?
Regular HbA1c monitoring.
HbA1c should be done. How many days? In how many days you can ask for HbA1c?
3 months.
3 months. What is the normal HbA1c?
Sir, less than 6.5.
Normally 6.5. In a diabetic patient?
Around 7.
Less than 7 is okay. Some books recommend, now newer guidelines, even it is less than 7.5 itself, it's okay. Pregnant ladies? Again, it has to be 6.5. Pregnant ladies, very tight control. Normally, you require 7. In elderly individual, even if it is less than 7.5, it is okay. What it tells you that HbA1c?
So the amount of hemoglobin that is glycated. So since the RBC's life is 120 days, it gives us the picture of like the.
So last 3 days picture you get. 50% is contributed by last 1 month. So you get a better picture of last 1 month. You get a picture of overall picture of 3 months, but you get a better picture in the last 1 month. So 50% of the value is contributed by last 1 month's sugar value. If the patient sugar is not getting controlled, you have to increase the insulin. What insulin we are giving?
We can give a baseline NPH and then.
Okay, baseline means night time we give an NPH and daytime we give Actrapid 3 doses. Okay, then once you are discharging the patient, we have to give long acting insulin because otherwise they don't take. 3-4 times at home they won't take. And if the hospital sugars are controlled, when they go home, sugars again it will come down. Why they come down? Why it come down? Because their activity increases. In hospital their activity is very low. So suppose you are giving 100 units in a day, when they go home they may require only 80 or for 60 units because their activity increases. That also we should keep in mind. Follow-up is very important. Okay, thank you.